Chapter 11 covers emergency planning and injury evaluation. An emergency action plan is a comprehensive document that outlines how an emergency situation will be handled. Emergency plans can be thought of as blueprints. Like blueprints that must be drawn before the building is built, the emergency plan must be in place before it is needed. Proper planning will allow the sports medicine team to respond to an emergency smoothly. The ability to respond when called upon may make the difference between life and death. In addition to planning, teamwork is the second essential component of the response plan. Everyone involved must know their role, work within their boundaries, and be prepared to act accordingly. Emergency plans are not one size fits all. The plan must be specific to the sport activity in question and will need to be tailored to specific facilities. Compare the needs of the athletic trainer at a track and field event to one at an equipment-intensive event like a football game. How you immobilize, transport an individual with a suspected cervical injury will require some equipment-specific planning. The most common equipment example is having a plan to remove a football helmet face mask if needed. The two main questions that an emergency plan should address are as follows. What are the roles and responsibilities of each member of the sports medicine team as they respond to an emergency? And what steps will be taken to activate emergency medical services? Emergency documents should not be written for the sole benefit of the sports medicine team. The plan should be distributed to administrators, coaches, facilities, staff, and any personnel who may be impacted by such an event. While plans must be flexible, each should provide information on implementation, personnel, emergency equipment, communication, transport, venue location, emergency care facilities, and documentation. Table 11-1 discusses best practices for emergency planning in athletics. Athletic trainers must be prepared to assess emergent injury situations as well as the more common non-life-threatening injuries. Any on-the-field injury assessment begins with a primary survey. The primary survey involves an assessment of the ABCs, airway, breathing, and circulation. The primary survey also requires that you establish the presence of severe bleeding. At any time during the primary survey, an athletic trainer must be prepared to activate an emergency action plan that includes summoning EMS, establishing an open airway, giving CPR, and providing first aid. Emergency care is a series of decisions, and what you find as you assess the ABCs determines what steps must be taken. Figure 11-1 shows a typical decision tree for assessing an emergency. Athletic training students must be equipped to assist athletic training staff in the event of an emergency. Athletic training students in clinical rotations should be trained and hold a certification in CPR, including the use of an AED, trained in basic first aid care, the use and maintenance of emergency care equipment, and know the location of such equipment. Students may be asked to assist supervising staff in acting in an emergency plan. Phoning EMS, assisting with CPR, spine boarding, and patient conveyance are all potential emergency situations for which an athletic training student should be knowledgeable. It is the responsibility of the athletic training program to ensure that students are well equipped to handle emergency situations prior to being placed in their clinical sites. While the athletic trainer should always be ready in the event of an emergency, most on-the-field evaluations and decisions are non-emergent. In this situation, the athletic trainer must then perform a secondary survey. The secondary survey is a survey for trauma once you have established that the patient is stable. Throughout the secondary survey, the practitioner must always continue to assess ABCs while checking the patient from head to toe for additional signs of trauma. The secondary survey should help the athletic trainer determine the safest method for removing the athlete from the field of play. A more comprehensive evaluation can be performed once the athlete is on the sidelines or in the athletic training facility. A comprehensive evaluation consists of taking a history and carrying out physical examination. This type of evaluation is performed when an athlete or patient comes to you with an existing problem or on the sidelines after an acute non-emergent injury. These evaluations will most often follow the SOAP format. SOAP is a format for evaluation and documentation that stands for Subjective, Objective, Assessment, and Plan. Subjective information is any information gathered from the patient, while objective information involves the visual information or anything you see or notice and the results of tests that are performed by the athletic trainer to rule in or rule out specific pathologies. Assessments are the results of the evaluation. They are an impression of how the injury occurred and how the severity of the injury or grading where applicable. The plan outlines what management, treatment, or referral actions will be taken to care for the injury. Athletic training students should only do an evaluation if they have been properly instructed in evaluation techniques and are under the guidance of a supervising athletic trainer. While the SOAP note format for evaluation and documentation guides the evaluation process, the steps in an evaluation are often remembered by the acronym HOPS. This stands for History, Observation, Palpation, and Special Tests. Each section will now be outlined in detail. As the word implies, the history is what has already happened. The athletic trainer must gather information from the patient. This subjective information is critical to establishing a starting point for the athletic trainer to begin his or her search for the underlying injury that has brought the athlete to him or her. During a history, the athletic trainer must ask questions to determine the following: mechanism of injury, history of previous or related injury, onset of symptoms, location of injury, what type of pain is present, any abnormal sensations, anything that makes the injury better or worse, what treatment has been done, and if they are taking any medications or supplements. Of all of the questions the athletic trainer will ask the patient, the mechanism of injury and previous history are the most informative. In addition to the question topics previously mentioned, using the sample method can help an athletic training student remember what types of questions to ask during evaluation. SAMPLE stands for signs and symptoms, allergies, medications, past or pertinent medical history, last meal, and events leading to the episode. The athletic trainer must observe the area of the injury as well as the overall actions of the patient for the following: swelling or edema, discoloration or ecchymosis, deformity, signs of infection and inflammation, the patient's facial expressions to indicate pain, presence of a painful or abnormal gait, smooth and coordinated movements, and always comparing bilaterally where applicable. With practice and experience, the athletic training student will learn to gather observational information while asking questions during the history phase. To palpate means to gather information with your hands. You need to palpate the proper structures to gather information. This brings to light a general assumption of the evaluation process. You must have a strong knowledge of the anatomical structures to gather appropriate information. During a physical examination, you can palpate for the following: pain, crepitus or crunchy sensation associated with soft tissue overuse injuries, swelling, deformity, muscle tone, and changes in temperature. Palpation may be uncomfortable for the patient. Therefore, the athletic trainer must proceed with caution and palpate areas that he or she suspects will be painful last. There are a number of different tests that fall under the umbrella of special tests. They include range of motion, ligamentous and special tests, and neurovascular testing. Range of motion testing refers to the assessment of range of motion, active, passive, or resistive. Active range of motion is the motion that the patient can perform on their own. Passive range of motion is a motion where the athletic trainer performs the motion with the patient relaxed to get a feel for the end ranges of motion. Resistive range of motion is where the athletic trainer applies resistance to the patient through the full range of motion to determine any weaknesses in the range. This range of motion test is also graded based on the strength of the muscle given the amount of resistance it can move through. If a patient is unable to perform an active range of motion or has pain with passive range of motion, the athletic trainer should not perform resistive range of motion. The athletic trainer utilizes ligamentous tests to apply stress to the joint and determine if the specific structures have been injured. These tests allow the athletic trainer to identify sprain injuries. Special tests are designed to help identify specific injury or conditions based on a particular maneuver by the patient or the action by the examiner. Several acute and chronic injuries can affect nervous or vascular structures in the body. Nerve injuries may cause changes in sensation, muscle weaknesses, or loss of function. Athletic trainers evaluate neurological function by assessing dermatomes, myotomes, and deep tendon reflexes. Dermatomes are sensory areas of the skin that are supplied from specific nerve roots. Myotomes are muscle actions that are related to a particular spinal nerve root. Deep tendon reflexes assess injuries at specific nerve root levels based on the injury to the nerve root. It is important to be skilled in assessing the neurological status of an injury for the purpose of initial care and appropriate referral. It is also common practice to check for circulation by checking the pulse distal to the site of a traumatic injury, such as a fracture or dislocation. Vascular structures may be affected by both acute and chronic injuries. Taking the pulse and confirming normal circulation should be part of any physical examination. It is common that the patient may need further diagnostic testing following a thorough evaluation. Diagnostic testing through the use of radiographs, magnetic resonance imaging or MRI, computed tomography or CT scan, or ultrasound are used in a variety of situations associated with injuries and conditions the athletic trainer will encounter. Other imaging choices are available, but outside of the scope of this introductory text. Radiographs or X-rays are a form of radiation much like light or radio waves that can be focused into a beam. Unlike normal light, X-rays can pass through most objects based upon the density of the object. When X-rays strike a piece of photographic film, they produce an image. What is seen on the image depends upon the density of the tissue. Dense tissue, such as bone, absorb many of the X-rays and appear white on the picture. Less dense tissue, such as muscle and organs, absorb fewer of the X-rays and they appear in shades of gray. If the X-rays pass through the air, they will appear black. MRI uses radio frequency waves and a strong magnetic field to provide clear and detailed images of internal anatomy. Biologic tissue, when placed within a strong magnet, can be induced to give off a detectable signal immediately following stimulation by a pulse of radio frequency energy. Different types of tissue give off measurably different types of tissue-specific signals following the administration of the same radio frequency pulse. It is these predictable differences between the signals from one tissue type versus another that allows an MRI to produce meaningful images. MRI in athletic training settings is widely used to examine soft tissue structures in the joints. MRIs can also be helpful to look at inflammatory processes in bones and thus with the use of overuse injuries that do not readily appear on traditional radiographs. MR orthography is a type of MRI that involves the placement of a contrast dye in the joint prior to the MRI in order to see specific structures in greater detail. CT is a procedure that processes information from an X-ray beam that creates a cross-sectional three-dimensional image of the area being scanned. CT is often used to image complex fractures, especially around the joint, because of its ability to reconstruct the area of interest in multiple planes. The advantage of a CT scan is the ability to view the anatomical structure from many different angles. It is common that the ultrasound of sonography involves high-frequency sound waves to produce images of anatomical structures. Through the use of radiographs, healthcare professionals use them to view the heart or MRI, blood vessels, kidneys, computed tomography, and other organs. Scan, or ultrasound are used in a variety of situations associated with injuries and conditions the athletic trainer will examining the fetus during pregnancy. Other imaging choices are available, but outside technology of the scope have allowed for images to be seen in three dimensions. Radiographs or X-rays ultrasound is being used more of radiation to aid in the diagnosis radio waves that can be focused into a beam. Its non-invasive nature and lower costs X-rays can pass through most objects. The real-time capture of the images allows for structures to be examined functionally. When X-rays strike a piece of photographic film, they produce the underlying tendon. What is seen on the image depends. The athletic trainer must possess the skills to evaluate both emergent and non-emergent injuries to determine an appropriate course of action. Primary and secondary surveys are evaluation schemes that allow the athletic trainer to properly assess the injured individual, render initial care, and make the necessary referral. The initiation of an emergency response plan is the appropriate action when the athletic trainer identifies an emergency. Institutions and organizations must have a well-documented and frequently rehearsed emergency action plan. After the secondary survey is completed and is determined if the patient needs to be transported for further treatment or not, a complete history and physical exam should be completed using an organized evaluation process. An athletic trainer who understands anatomy and proper function of musculoskeletal structures will be able to evaluate and make decisions on the proper management and care of a patient who sustains an injury or illness and be able to recommend the best course of treatment. As athletic trainers find themselves in a wider range of healthcare settings, they will need to be more familiar with a variety of diagnostic tests. Imaging tests commonly associated with injury evaluation and diagnosis are commonplace in sports medicine settings. The athletic trainer is often called upon to educate the patient regarding the nature of diagnostic procedures. Athletic trainers must have an understanding of diagnostic imaging choices and appreciate their application and use under specific conditions.